Hello friends, welcome so much to my YouTube channel, the Dr. Krishnan lecture. I am Dr. Krishnan, doing super specialization in neurology at Indraprastha Apollo Hospital, New Delhi. Do subscribe to my channel for more and regular updates on interesting topics of the medical science. In this lecture video, I will discuss about interpretation of arterial blood gas analysis. The content of my presentation include introduction to acid-base disorder, normal acid-base physiology, indications for performing an ABG analysis, practical approach to acid-base disorder, different cases of acid-base disorder, and 10 commandments of ABG. So, what is acid-base disorder? Acid-base disorder can be respiratory acidosis or respiratory alkalosis, and this can be acute or chronic events. It can be also metabolic acidosis or metabolic alkalosis. Respiratory acidosis being pH on the lower sides, increased PCO2. Respiratory alkalosis being pH on the higher side with decreased PCO2. Whereas Y-carbs are in the normal range. Metabolic acidosis being pH on the lower side with decreased bicarb level, and metabolic alkalosis being pH on the higher side and increased bicarb level with PaCO2 being in the normal range. Then comes acidosis or alkalosis and acidemia and alkalemia. Acidosis or alkalosis is the process that tends to increase or decrease pH level. Metabolic acidosis or alkalosis affects bicarb, whereas respiratory acidosis or alkalosis affects PaCO2 level. Acidemia or alkalemia tends to affect all primary and compensatory changes on the arterial blood pH. This figure depicts the normal acid-base physiology in our body. Following metabolic process in our body, carbon dioxide and hydrogen ions are produced. This carbon dioxide reacts with water to form H2CO2, which breaks down into hydrogen ion and bicarbonate. Hydrogen ion is excreted from our body in the form of ammonium ion and PCO2 from our lungs. And because of this pathophysiology, the pH of our body is maintained in the range of 7.35 to 7.45, PCO2 in the range of 32 to 42 mmHg, PaO2 between the range of 75 to 100 mmHg, and bicarb in the range of 22 to 26 milliequivalent per liter. It is because of these metabolic process as well as compensatory change, our body is maintained in a constant pH, which will help in the body metabolic process. This is how normal ABG is interpreted in our labs. Measured value should be considered and corrected value should be discarded. Then, what are the indications for performing an ABG analysis? First one is to evaluate the adequacy of ventilations, that is with the level of PaCO2, acid-base status, that is through pH and PaCO2, oxygenations through PaO2 and SaO2 status, oxygen saturations, oxygen carrying capacity of the blood through partial pressure of oxygen, hemoglobin oxygenations, hemoglobin total level, dyshemoglobinemia, and to quantitate the patient response to therapeutic interventions and or diagnostic evaluations through oxygen therapy and exercise testing, and to need to monitor severity and progressions of a documented disease process. So, these are the indications for performing an ABG analysis to evaluate the adequacy of ventilations, acid-base disorders, oxygenations, to quantify the patient response to therapeutic interventions, and to monitor the disease severity and progressions. Then comes the practical approach to acid-base disorder. Step 1 is to obtain an appropriate lab value. Step 2 is to determine if primary disorder is acidosis or alkalosis. Step 3 is to determine the source of primary disorder. Step 4 is to calculate the anion gap. And step 5 is to look for a mixed acid-base disorder. Then comes the step 1, that is to obtain an appropriate lab value. In order to assess acid-base disorder, the following lab values are necessary. That is arterial blood gas, pH value, partial pressure of oxygen, partial pressure of carbon dioxide, and bicarb level. With the comprehensive metabolic profile like sodium, chloride, carbon dioxide, and albumin. Step 2 is to determine if primary disorder is acidosis or alkalosis. If pH is less than 7.35, then primary disorder is acidosis. And if pH is greater than 7.45, then primary disorder is alkalosis. Step 3 is to determine the source of primary disorder. Acidosis with pH of 7.35. If PaCO2 is greater than 42 mmHg, then primary disorder is respiratory acidosis. And if bicarb is less than 22 milliequivalent per liter, then primary disorder is metabolic acidosis. If primary disorder is alkalosis with the pH of greater than 7.45, and if the PaCO2 is less than 38 mmHg, then primary disorder is respiratory alkalosis. And if bicarb is greater than 26 milliequivalent per liter, then primary disorder is metabolic alkalosis. Then we have to look for the compensatory changes. In respiratory acidosis, with the increase partial pressure of carbon dioxide, there will be increased bicarb level as a compensatory response. In acute event, for every 10 mmHg increase in the PaCO2, there is increase in the 1 milliequivalent of bicarb level. With the maximum limit of compensation will be 38 milliequivalent per liter. Whereas for the chronic event, for every 10 mmHg increase in the PaCO2, there will be increase in the 4 milliequivalent of bicarb level. With the maximum limit of compensation will be 45 milliequivalent per liter. In the respiratory alkalosis, the primary event will be decrease in the partial pressure of the carbon dioxide. And the compensatory response with these decrease in the carbon dioxide level will be decrease in the bicarb level. For acute event, for every 10 mmHg decrease in the carbon dioxide level, there will be decrease in the 2 milliequivalent per liter of the bicarb. With the maximum limit of compensation will be 8 milliequivalent per liter. And for chronic event, for every 10 mmHg decrease in the PaCO2, there will be decrease in the 5 milliequivalent per liter of the bicarb. With the maximum limit of compensation will be 15. Whereas for the metabolic acidosis and alkalosis, the primary defect will be decrease in the bicarb or increase in the bicarb level respectively, with the compensatory response being decrease carbon dioxide and increase PaCO2 level. With the expected compensation will be 15 plus bicarb level, with the limit of compensation for the PaCO2 will be 15. For the metabolic alkalosis, the expected compensation will be 15 plus bicarb level, with the limit of compensation will be 55 mmHg. It is to remember that respiratory compensation is always fast, which occurs within 12 to 24 hours, whereas metabolic compensation is slow and it occurs between 5 to 7 days. A step 4 is to calculate an anion gap. Anion gap is sodium minus chloride plus bicarb, and here bicarb represents the venous carbon dioxide. If serum albumin is less than 4 gram per deciliter, then anion gap should be corrected with the formula of 4 minus serum albumin concentration into 2.5 plus calculated anion gap. Thus, normal anion gap is in the range of 12 milliequivalent per liter and composed of albumin. It also contains phosphate, sulfates and other anions. If anion gap is greater than or equal to 20, then metabolic acidosis is either a pro-primary disorder regardless of bicarb or pH value. The reason behind this is that body will not generate an anion gap greater than 20 even in face of chronic alkalosis. If primary disorder is metabolic acidosis, the anion gap is greater than 12 milliequivalent per liter, then it is a case of high anion gap metabolic acidosis. And if anion gap is less than 12 milliequivalent per liter, then it is a case of normal anion gap metabolic acidosis. Task 5 is to look for mixed acid-base disorder. That is to calculate excess anion gap and add it to the bicarb value. That is excess anion gap equals to calculated anion gap minus 12. And here the bicarb value represents the venous carbon dioxide measurements. If excess anion gap plus bicarb is greater than normal serum bicarb, it is 20 milliequivalent per liter, then extra bicarb has been added to the serum and metabolic alkalosis is also present. And if excess anion gap plus bicarb is less than normal serum bicarbonates, that is 23 milliequivalent per liter, then it is a normal anion gap metabolic acidosis is also present. So let us discuss with a case that how we will interpret an AVG. First is to obtain an appropriate lab value. Obtain the pH being 7.5, PaCO2 being 20 mmHg, bicarb being 15 milliequivalent per liter, sodium being 140, chloride being 103. Step 2 is to determine primary disorder. Here the pH of greater than 7.45, so primary disorder is alkalosis. Step 3 is to determine the source of primary disorder. With the PaCO2 less than 38 mmHg, so the source of primary disorder is respiratory alkalosis. Step 4 is to calculate the anion gap, and here the anion gap comes to 22 milliequivalent, and here the anion gap is greater than 20, so metabolic acidosis is the chronic primary disorder along with the respiratory alkalosis. Step 4 is to calculate excess anion gap, and here excess anion gap comes to be 10, and excess anion gap plus bicarb is 25. So there is no other acid-base disorder. So this is a case of respiratory alkalosis with metabolic acidosis, and this can occur because of aspirin overdose, as salicylate stimulates the respiratory tract leading to respiratory alkalosis. They also causes high anion gap metabolic acidosis because they inhibit cellular metabolism, which leads to formation of keto acids and lactic acids. Thank you so much for your kind attention and watching my lecture. I will end up my today lecture with a beautiful quote defining success. That is, define success on your own term, achieve it by your own rules, and build a life you are proud to live. With this, I will end up my today lecture. Thank you all.